So let's a little bit practice for the like a those ABG yesterday that we talked until the others join. Okay, yeah. So it's a guy with a COPD, I would say 50 years old. Come now the so has this type of do you want to start? Do you want to interpret? So pH is low is acidosis. Uh-huh. So respiratory acidosis. And then what's the formula for prediction of bicarbonate? So now you're in the respiratory acidosis avenue, right? What was the formula? Uh-huh. So this one is 50, so increase by 10. So in a chronic setting, you expect it to increase by 3. So 24 should be 27, right? But what is this one? Is not only didn't go up, it goes down even. Yeah. So this one is has respiratory acidosis plus metabolic acidosis. Okay. So now, this one. So this is acidosis, respiratory or metabolic. Respiratory, is it compensated? So for each 10, your bicarbonate should be increased by 3, right? So it's going to be 27, right? What is the number here? So it's compensated, right? Okay, so that next one, okay, can you, so he's saying is acidosis because the pH is below 744 and said respiratory because PCO2 was above 40, right? And what's the expectation? Expected, huh? Alkalosis, right. So you saw in a some same scenario, almost I didn't change the first three, just the last one that I changed. It could be from like a pure respiratory acidosis or mix, means with the metabolic acidosis or metabolic alkalosis. Okay, let's do one more since people are still are coming. We start 8:15. So this one, I make it younger, like 20 years old, and I this is the one I'm saying it's like it means it's not a chronic patient. Is it like acute? So like somebody took some medication or some issue. So this one came with the breathing problem. Okay. Uh, who's gonna interpret respiratory acidosis with compensation? So can you tell me about the, so I get this one because it's acidosis, and I get this one that is respiratory. So what's the calculation for compensation? Yeah. So if it was pure compensated, it should be 26, but this one is so it means plus metabolic alkalosis. So it's like a somebody that took some tranquilizer and is like a coma, caused metabolic respiratory acidosis, and didn't eat or drink for a long time, so has metabolic alkalosis too. Okay, so uh, okay, so this one, Pauline. So first, alkalosis or acidosis? So acidosis, and why you said metabolic? Okay, yep, because this is low. So metabolic acidosis, is this compensated? What formula you use? You're in the different avenue. They call, let me, winter formula, right? So tell me what's the PCO2 expected? 12 times 1.5 is 6, is 18, plus 8, 26, plus minus 2, 24 to 28, right? So this is compensated metabolic acidosis, right? So then I ask you one more things that you should check delta delta whenever you're in that avenue. You remember? Okay. So like for this one, if like Dr. Amadi come here and teach you guys, he use like a delta anion gap minus delta bicarbonate. When I do this, I would say delta anion gap divided to delta bicarbonate. So the concept is the same. It means for any changes in ion gap, you need to see exactly same changes in bicarbonate. So the ratio should be 1 to be pure, pure. If it's not 1, means something else is going on. So in this case, an ion gap, imagine is 32. Um, yeah, so let's check this one. Delta anion gap means like 32 minus 12 is going to be 20, right? Normal anion gap 12. So delta anion gap is 20. Delta bicarbonate is like 24 minus 12 is 12. So it's little bit more than 1. So that's the one. Each one of those that I told you guys, like if it's a more than 2, it means has another metabolic alkalosis. If it's 1.6, has another meaning. But just I want to tell you guys that when you're in that avenue, use this formula, don't mix them up. For this one, delta delta, and I think we yesterday we talked that apparently yesterday I said delta bicarbonate over delta anion gap. What is delta delta means delta anion gap to delta bicarbonate. Okay, so if we have time, we can back again to this practice again. Yeah. Check 24. Yeah. Okay, so let me. Okay, today I'm gonna talk about the. I mean, that's an excuse to talk about. Um, I said earthquake and the kidney. Um, the earthquake is very common things in the earth. So as I use this analogy, as long as we are alive, we always have something in our body moving, like my hands move, my chest wall, when you breathe, you're moving. So the earthquake is a sign of the, imagine that's the sign that the earth is alive. So um, overall, when you look at this, this is the one that I took last week, um, was the number of the earthquake that recorded in the world. Um, and then this is the area that I check for today. I mean, for here again, this is the last week. The number of the earthquake that mostly when you see is in the Puerto Rico area, and this area seemed was Barbados or something, was there was no earthquake last week. So I don't. So I'm gonna tell you guys a couple of a story that um, in June 21, 1919, um, an earthquake. It was a big one, caused a strong shaking in large part of Iran. At that time, I was interned. Um, so the part that was center of epicenter of the earthquake was in the south of the Caspian Sea, and it was very very strong earthquake. And this is the area that was happened before the um, earthquake. Very green area, and after that earthquake is changed everything to really completely um, brown. And when I was talking to the group of the local, um, I don't know, is anybody of you guys been in the area with the earthquake post or see the uh, that disaster? Is a huge, I mean, it's a just some unreal. Um, the amount of the energy that release in the mother nature is like an entire, like this mountain that you have. When I was there, they said there was a big mountain here and not anymore, is not exist. So basically, in a matter of 2 minutes, imagine how much energy is removed this like an entire mountain to somewhere or completely make it flat. Um, so that's the huge is a disaster. And then the time that in that earthquake, like fate, fatality was around 50,000 people. But the good things at that time was there was coincide by World Cup, and it was I remember was Brazil against another team, and everybody was up, although it was 1 a.m. local time, and people were basically up watching TV, and while this shaking happened. So at the time that this happened, so people had a chance to get out of the house, come to the street, and reduce the amount of the fatality. Otherwise, it could be a couple of 100,000 people. So after that, there was another earthquake in the area. At this time, south east of Iran. And at that time, this is the one of the historic castle, like more than 3,000 years old, was resist and stand up for million years. And then after that, it become totally demolished. So this is the 30,000 like view of the city. Completely, all these city was done, and many of those tradition houses that you see, they had some um, steel roof, but the walls were all mud brick, so no supporting beam. So with earthquake, everything is collapsed, and the people is stuck under this. The medical terminology that we use for this, we call it crush syndrome, means somebody crushed by the heavy stuff. So even when the amount of this scale of the earthquake is high, even the houses with the supporting beam, you see this X type of beam on the side, they may not totally collapse, but they not very completely resistant to earthquake. So even nowhere, even in the car may uh, crash. So what's happened then um, when God forbidden, imagine here you had an earthquake and then everything is become all the country is going to be paralyzed, all everything. So the people from neighboring city should come and help this city, because even if I'm a doctor, if you're a doctor here, if you have some disaster like that, you ha- you have some obligation or to go and help your loved one, your family. So you're still, even if some team come take the people out of the rebel, those people they're gonna go back, become part of rescue team. They're not gonna go to the hospital. Even in that situation, there is no hospital functional. So people come from the neighboring city to help, and then just if something happened here from the next island, if someone wants to come here to help and organize or come, it takes really 12 to 24 hours. So there, when earthquake come, there is no um, building considered safe to go there. So then they have to make a hospital in the with the tent as a outside. So these are the one that you see, and there is nothing really. The people on the so it's a really disaster, and the people like you get a lot of fatality. Um, so, but life is still going on after that. But this is like a after the earthquake. That see, there is everything. Um, you live in the tent, and then it's a really something that when you live in a tent, the bathroom or something, it shouldn't be on the closed. You put it like a half a mile further to not to get sick. So that's the real things. This is the another like a story about the magnitude of the scale of Richter, and from China, Japan, Turkmenistan, and everywhere you have this earthquake, and you see the fatality. The one that is like 1976, almost 255,000. They die in a matter of minutes. Um, so how they do this? So in 1988, there was a historic visit of Gorbachev to United States. So in that time, it's happened after many years Cold War, and it was one of the most important meeting in the history of mankind that these two leaders they want to just talk. So during this visit, what's happened is there was a one earthquake happened in Armenia in December 7, 1988, and just 25,000 people died. So in that time, Gorbachev had to leave the meeting and go back to see, be in the field. So when he back to Russia, I mean Soviet Union at that time, all the media follow him to back to cover the that earthquake. So in that time was the time that I would say they call seismonephrology, basically born. So in fact, many people after the um, this earthquake, um, when they go and some the people they remove them from under the rebel, when they come out, they look good. They, I mean, you were under the rebel, so we remove it. You come out and you set up good. So you go back to this, but the problem is the kidney shutdown will happen in like a day 6, and the many people die because of the kidney shutdown a couple of days later that we're gonna discuss about today. Um, so based on that media and this story that happened, um, at that time, official of the Soviet Union requested assistance for this amount of the problem that they had. And at that time, American Society of Nephrology, in annual meeting, started to make effort for the dialysis and make a task force they call Renal Disaster Relief Task Force. Um, so they had several section, and then so it's still many this is the part of even came to the New England Journal of Medicine about this issue. um, and you guys heard about the Haiti that 222,000 people died. And then so the reason of this one is, as I show you guys, if you're under the um, in the house and just the ceiling collapse and you're stuck under this, so the pressure of those material on the muscle is cause muscle damage, and you some of the muscle release, I mean whatever inside the muscle, and cause injury. So I'm gonna just review those mechanism of this one, and with that one probably we review entire physiology of the kidney with the just one disease. So this crush syndrome that I was saying is because of the crush. It's um, caused mainly by rhabdomyolysis. You have rhabdomyolysis in a different setting, like some of the people that they use drug, like IV drug abuse, they may get this one. Some people that they go in like in the humid environment, do exertional, very heavy exercise, they may end up with the rhabdomyolysis. Some people that um, they go for like even neurosurgery um, operation and stay in some position for maybe 10 hours, they may get, uh, even when we sleep, if you, for a long time, all the time we turn left, right, so we prevent that rhabdomyolysis. But some of the people that they are using drug and became unconscious, they may get rhabdomyolysis. So that's the common denominator of the crush syndrome, IV, exercise, everything is become for the crush syndrome, rhabdomyolysis. So how they found the people, one of the first sign that they may see is their urine is become like a Coca-Cola. So the cola color urine is one of the sign of the rhabdomyolysis. So, and then how we find out in the what's the lab marker or biomarker to diagnose is you're checking the CPK, creatine phosphokinase, or CK. It should be more than like a classic one, more than 20, 30,000, but it could be more than 1,000, 100,000. So anytime that your intramuscular mechanical force above diastolic blood pressure, you may have this muscle injury. So these are the six main mechanism of the problem. So one is a hypovolemic shock. So how did it happen? When you're under um, rebel or rhabdo, something happened. The muscle has some cell membrane, and that cell membrane, as we discussed, has like a lot of pumps, sodium, potassium, ATPase, to maintain this integrity of the muscle. When that's damaged, then the fluid or some stuff is not going to function the same as before. So many of those maybe started bleeding, just release, you get hypovolemic. Some of the fluid maybe now gets to the muscle and it become muscle um, um, become hypovolemic because fluid moved from the intravascular to the muscle. When you have a tissue damage and the cell necrosis, when cell completely open up, and as you guys know, the potassium is the main um, intracellular ion. So those potassium come to the circulation, and you may get hypercalcemia. So hyperkalemia. So hyperkalemia that we discussed the other day in the class, and cause cardiovascular instability, and you may die for that. So when the muscle release some of those fatty acid, release and absorb calcium, and you get hypocalcemia, and they may get Cs. Metabolic acidosis is another um, uh, issue that they may get, and is because many reasons that I'm going to tell you guys in a minute. And renal failure and compartment syndrome that I'm going to briefly go through this one. So this is the I mentioned about the hypervolemic shock. It's because of the um, swelling of myocyte. I mentioned about the hyperkalemia because potassium release you have in a large amount. And one of the things that yesterday, I think yesterday or 2 days ago, we talked about the if you guys have hyperkalemia, how you treat. You remember? You give the first calcium, right? I think you why we gave calcium for the cardiac instability. And then what else was treatment for hyperkalemia? Talk about this. Insulin, glucose. You remember? Yeah. So what was the insulin and glucose do? Yeah. Shift the potassium from outside into the cell. Yeah. But mostly we treat that one because of the um, potassium get into the cell. So the other things that we do is to prevent renal failure. This is the one thing that um, you want to prevent. In the normal setting, we don't have myoglobin in the kidney. So let me change this one to in a normal. If this is that nephron, in the normal setting, we said some stuff get filtered into the kidney and then the nephron goes. Sometimes the some when you have a rhabdomyolysis, those myoglobin that is came out of the muscle release, and per se, this myoglobin is nephrotoxic. So it's caused damage to this epithelial cell and cause this nephron completely out of the system. The one of the things that I imagine this is the tubule epithelial cell. When they expose to myoglobin, these cells is just connected to the basement membrane, which is like a hook of like a curtain. So when they stuff to the exposed to the myoglobin, they become loose and those fall into the lumen. And then when you have a lot of those together, is become clogged and block the this lumen, and then lumen is not going to be functional. So the things that you want to prevent to tubular damage, and because of the myoglobin or uric acid, to prevent this obstruction of the kidney. So the other things that um, we call it reperfusion syndrome or compartment. Um, this is another complication of the this disease. Um, every um, muscle that we have a fascia around the muscle is completely covered. If it's something happen in the muscle and you have bleed or something, this fascia completely cover it, doesn't let come out. So one of the things that in the rhabdomyolysis patient is a necessary, is a must and recommended is just touch and examine the patient after that one. Means you, especially is a big muscle like a quadriceps or something, touch it or the calf. If they said, is it painful? It means there is something going on over there. What's recommended, um, because it's one of the complication of the rhabdo or crush syndrome, that they may get compartment syndrome, not happen to everybody, but usually we put some like a um, instrument and they measure the pressure. If the pressure is high, you said, okay, this is the compartment syndrome. And then if it's an acute phase and you catch it right away, you ask the surgeon and they go the fasciotomy, they open that one and the pressure release. Otherwise, if you keep it, those high pressure cause muscle necrosis and then they die, those muscle die. So the point is in the every day you have to examine and you catch it very fast and do the ask for the intervention for the surgical intervention. So when you find the patient diagnosed with this, you have to start treatment with the really one of the highest amount of the fluid in the medicine that you give is in the setting of rhabdomyolysis. Means if somebody had, I don't know, like a diarrhea. So when you treat it, you said, re- usually if you see in the hospital 100 cc per hour, it still is considered is a good number. But in the setting of the rhabdomyolysis, you may go up to 500 cc per hour, like 5 times more than normal. Even sometimes, if I order 300, 500 per hour, is something very unusual for the nurses. And then they come and said, how much you wrote? Is it 500? Is it 300? And some of them you have to tell, yes, give it. It's 300, is necessary. And you have to convince them. Sometimes the nurse said, I don't feel comfortable. They said, feel comfortable. This one, you have to go with the high amount. The whole idea is just to make the people have diuresis to prevent those um, clog formation that I mentioned in the tubule, to not have time because they have good flow of the urine, that those myoglobin or something, those um, tubal cell, when they shed into the tubule, don't get clogged, and just you have a good flow. So the this is very important. Just rhabdomyolysis needs high amount of fluid. There was a one study that they done in Israel in the same thing in the bombardment or something. Then when the people is stuck under this, they call three limbs study. They noticed that even if three limbs is under the um, rebel and one arm is out, they said start IV fluid from this, and then they try to remove them. The outcome is better when they have you started treatment sooner. Um, so, so the treatment, as I said, the main treatment is early treatment for the IV therapy. So some of the, despite of whatever you do, sometimes the kidney goes toward the kidney shutdown and then not working and needs to do for dialysis. And then many of those, they may die even. So um, usually in the earthquake, in those type of disasters, many people die on the first day. So that's what. Some of the people that they survive and just come out, they think is okay, but it takes time. Those myoglobin completely damage kidney and kidney shutdown happen and your creatinine goes up. So usually day 6, that's the time that they become symptom. They become nauseous, no energy, no appetite. When they come, you realize that they have kidney failure and they may need dialysis. And then some subset of this group, they get muscle pain and they go for the compartment syndrome. And then you have to ask them, for the surgery to do fasciotomy. This fasciotomy, just remember, it should be immediate in the acute phase. If you find it now, right away. If it takes like 3 days, 4 days, and then you find out and you said, oh, this is 4 days pain, this, at that time, if you do fasciotomy, the mortality is higher and morbidity is higher. But many of those study, um, despite of the many data that is outside, but still they do fasciotomy, and then they have this data from the like Turkey, from the Iran, from Japan, from China, all showed that fasciotomy in a chronic phase has higher morbidity, including bleeding and sepsis. But still, the surgeon does when they see um, compartment syndrome, they do fasciotomy. So the things that I wanted to ask you guys that examine the patient with rhabdo every day to catch the compartment right away. So the second story that I want to just tell you guys is in India there was a cholera epidemic, and then the people would die with diarrhea because of cholera. So some group they decided to say, okay, how we can manage or reduce mortality. They said if we could find a way um, from the imagine someone get diarrhea in the village to reach to the um, tertiary center or some center to medical center to get the IV, majority of the people would die in that time frame. He said how we can manage these people in that transition from the home to the hospital survive until they get antibiotic or IV medical. Then they come up with some solution. They said, okay, if we give oral solution, we might be able to manage this group in that transition. So then they come up with this Pedialyte, or the one that you see in the US, or oral rehydration solution. That's buy a time for you guys that to help people from the home to the hospital. So with the same type of concept that if you get um, time with the same rationale, um, we come up with some solution to like an oral solution to give to the people with that in an earthquake area to use that one as a like a bridge. Uh, because as I mentioned, if somebody, God forbidden, is stuck in that earthquake, and then I rescue you from rebel, and I said, okay, I have a truck or hospital here, and you're at risk for the renal failure. Let me just give you fluid. You said, still my son or my daughter is here. You're not going to go to the hospital. You said, you become part of this to make sure everybody's out or your neighbors or everything. So that's the time that is very critical to save your kidney. And mostly during the earthquake, there is no food, there is no, I mean, maybe just the water. That's the only thing that you may have. But the water alone may not be enough. The reason for that one is um, anybody knows what is isoelectric pH? What's that mean? So she said this means everybody understood, right? Means there is a pH that the amount of the ionized and non-ionized are the same, is equal. For each molecule, this isoelectric pH is different. Like for myoglobin, the isoelectric pH is 6.1. Means if you increase your urine pH from 6.1 to 7.1, 90% become non-ionized and the kidney is able to dump it. If you make the urine pH from 6.1 to 8.1, almost 99% become non-ionized and you can dump it. So with the same rationale, because we knew that the isoelectric pH of the myoglobin in 6.1, we designed a solution to make the urine alkaline, and we had to make this solution become isosmolar, and we have to make it to the way that make urine alkaline to bring it the urine pH to the 8. And then at the same time, it shouldn't have any potassium because with the rhabdo, they had tendency to have high potassium. So we make a one solution with the like a powder to mix it and then give it to those people to see. This was the phase 1 study. We make a some group of volunteers to take this one for 12 hours, and the plan was to make the urine output of 200, and then we noticed that the urine pH is became more than 7 in 3 hours. And then the conclusion was maybe if we use in that setting some type of oral agent to make urine alkaline, might be some of the preventive method for the to buy a time from the field to the medical center to get the treatment. So, um, so the same story for the many times you want to buy a time in like a diarrhea, you want to buy a time to get the real treatment. You want to be not to collapse because of cardiovascular instability. With the same crash syndrome, um, with they may get hypovolemia, so you have to give fluid. And as I mentioned, the amount of fluid it should be very high. Um, if you're on the floor and they said, okay, this patient um, has rhabdo and don't go with 100, go higher, 300, 400 cc per hour. Then the hyperkalemia is a real, you have to treat it with those calcium and those insulin and the glucose that we discussed the other day, and then they may get hypocalcemia. There always you have to correct that one for this treatment and follow kidney function because they may get worse and then they may need dialysis. Um, and the last one, examine the muscle to make sure there is no compartment syndrome. You get that one. Um, any question for this part? Okay, so we have 5 minutes. Today is the last day of first week of renal. So I'm gonna just go a little bit more practice for the um, acid base one to make sure that at least you guys memorize this couple of formula that I mentioned. Um, so let's do 60-year-olds male in ICU and sorry, yeah, yeah. Okay, so um, who wants to? Okay, so this is metabolic acidosis because of the acidosis, and this is metabolic, right? Because of this state. So is it compensated? Hmm? So based on the winter formula, you 8 times 1.5 is 12 plus 8, 20. So it's gonna be between 18 to 22. That's your expected, right? So means the bicarbonate from 24 should come down and something's, sorry, your PCO2 from 40 should come down and something between 22 to 18 should stop in this range, right? So this one is exactly is this. So it's a compensated metabolic acidosis. So then can you tell me about the delta delta? So delta anion gap is 32 minus 12 is 20, right? And delta bicarbonate is 24 minus 8 is 16, right? So delta delta is 12 over 16. So it's gonna like a 5 over 4 is 1.2, right? Something like that. So it's very close. Okay, so that's awesome. So let's do one more. Okay, and anion gap, I make it just- okay. So someone from, do you want, do you want to do that? So she doesn't want. Do you want to go? What? Okay, so this is acidosis, and this is metabolic acidosis. So is it compensated or no? Okay, so is it 10 times 1.5 is 15 plus 8, 23 plus minus 2 is going to be 21 to 25, right? So this one is 16. Yeah. So means metabolic acidosis plus respiratory alkalosis. And not delta delta, uh-huh, is going to be 28. 10 is 14, right? So delta delta is 28 divided to 14 is 2. And I said if any number above 2 has metabolic alkalosis too. So this one plus metabolic alkalosis. So it has a 3. So this is the, I mean, it's very toughest one that you guys did. And it's so impressive. You guys are still first year and you're able to do this one. Um, okay, so I think we are exactly on time. So it was nice this week working with you guys, and hopefully next week, next 2 weeks, with the continuation of this renal, you have a better time. That the first week of the renal is toughest. I don't know. Hopefully, I could give you guys some confidence that it's easy to understand and easy to. Uh, but every week is gonna be better. Um, when I decided, usually I was third week. I had the easiest job. Dr. Kazuri and Danish, in the first 2 weeks, they should sweat. But this time I was the first one. But I hope um, I gave you guys some, um, to me, is just confidence that it's not so tough. I can manage. It's easy, and and in reality, it makes sense because it's mostly like a math. Is more makes sense. But just my uh, 5 cents advice to you guys is um, the only things that the people in nephrology they said is hard because they mix up those formula. Uh, just make sure that all the time know in the acid base which avenue you are and which formula you should use. If you know that one is easy, um, don't mix them up or said, okay, I use winter formula for everything. It's not gonna work again. Okay, thank you and see you upstate, right? Thank you.